Welcome to PFT Tutor with Jeffrey Haynes. In this video, we're going to discuss avoiding bias when assessing dyspnea in obese patients. Hey, let's face it, we're all human, which means we're all subject to bias and jumping to conclusions based on that bias. As clinicians, we have to make a concerted effort to avoid this trap because it can cloud our judgment and lead to poor clinical decision making. As you all know, obesity is one of the most important public health issues in the United States and abroad. This map shows obesity rates by state. There's only a few states with obesity rates as low as 25 to 30%, as shown in yellow, and there are no green states with obesity prevalence less than 25%. One of the most alarming factors is the number of children with sedentary lifestyles spending hours staring at screens. When I was a kid back in the 1970s, we were lucky not to have these devices. When we weren't at school, we spent most of our time outside riding bikes, playing games, running all over the neighborhood until we were called home for dinner. So we should expect to continue to see a steady stream of obese patients complaining of shortness of breath. It is not surprising that obese patients report dyspnea on exertion because when compared to normal weight individuals, obese subjects experience an exponential increase in oxygen consumption as ventilation increases, especially with load-bearing exercises like running or climbing, resulting in dyspnea and exercise limitation. One of the obvious effects of obesity on respiratory function is the impact on lung volumes and capacities. The first lung volume to be affected by weight gain is not the vital capacity or total lung capacity, it's the expiratory reserve volume. As shown here, ERV rapidly declines with weight gain even when the BMI is less than 25. And you don't need to perform lung volume testing to see this. The patient on the left is thin and the patient on the right is obese. In the flow volume loop from the thin patient on the left, you can see space between the tidal breathing loop and the end of the expiratory flow volume loop. This is the ERV. In the flow volume loop from the obese patient on the right, there doesn't seem to be any ERV at all. The end of the tidal breaths are right up against the residual volume. Since the expiratory reserve volume is one of the two volumes forming the functional residual capacity, FRC follows a similar trajectory, rapidly declining with weight gain. Unlike ERV and FRC, the vital capacity and the total lung capacity have a more linear decline and usually only fall below the lower limit of normal at very high BMI. So as pulmonary diagnosticians, we recognize that gaining weight alone can reduce exercise capacity and produce dyspnea, and while the pathophysiology of obesity-related illness is complex, most of us feel that we have at least a basic understanding of the underlying mechanisms, for example, the effect of weight gain on lung volumes. And here's where we need to be careful not to fall into the trap of implicit bias. In healthcare, implicit bias refers to the unconscious attitudes and stereotypes that affect healthcare professionals' understandings, actions, and decisions regarding patient care. In the case of the obese patient with dyspnea on exertion, we have to be careful to avoid implicit bias and remove those blinders that might make us jump to conclusions and just assume that the patient's dyspnea on exertion is due solely to obesity. So let's review a few real-world cases that illustrate the danger of assuming that dyspnea in an obese patient is due only to excess weight. This is a patient I took care of. He was a 49-year-old male. He complained of dyspnea on exertion and when tying his shoes. He was 6 feet tall. He weighed 308 pounds. His BMI was 42. His physician ordered an exercise bronchoprovocation test, and I remember feeling a little skeptical. I mean, do you really think that exercise-induced asthma is his problem? So we got him up on the cycle ergometer and pinched his nose, and we had him cycle hard and fast while breathing compressed air for about 10 minutes. And 2 minutes after cycling, his FEV1 had fallen 30%. And you can appreciate the expiratory portion of the flow volume loop has become more concave. So my skepticism regarding asthma was clearly wrong, but that's okay. I learned a valuable lesson here. Learning from our mistakes is how we grow and how we get better at what we do. So obesity-related asthma is real. It's not just doctors issuing an asthma diagnosis because they're afraid to tell their patients that they're short of breath because they're too heavy. In this study, asthma prevalence is shown in subjects that are normal weight in blue, overweight in gray, and obese in green. As you can see, there is a much higher incidence of asthma in obese patients, especially in women. Patients with late-onset obesity-related asthma tend to have non-allergic or non-atopic asthma without type 2 inflammation. As shown here in patients with severe asthma, as the BMI gets higher, the sputum eosinophil percent gets lower. And because of this, there is a reduced clinical response to inhaled corticosteroids, as shown by the red arrow The number of asthma control days is lowest amongst obese patients taking beclomethasone compared to lean and overweight patients. This is a methacholine challenge from an obese patient that I tested. There is a significant response to methacholine, but a very low fraction of exhaled nitric oxide, or FeNO. So in my opinion, it's probably not a great idea to treat this patient with steroids because the low FeNO suggests an absence of type 2 inflammation, and steroids have the potential to make things worse via more weight gain. So in this patient, I would prefer to use a long-acting beta agonist or a long-acting antimuscarinic agent and focus on weight loss. I mentioned weight loss as a primary treatment of obesity-related asthma. In this study of obese patients undergoing weight loss reduction surgery, 1 year after surgery, all of the patients had a reduced response to methacholine with a higher PC20. In addition, this study shows that when obese patients with asthma lose weight, their asthma control questionnaire scores improved. Of course, one of the most important outcomes in asthma is reduction of exacerbations, and in this study of obese asthmatic patients undergoing bariatric surgery, following surgery and weight loss, there was a significant reduction in the number of exacerbations. Here's another real-world example of a patient with obesity and respiratory symptoms. So this is a 53-year-old male. He complained of dyspnea on exertion, especially when climbing stairs. He was 5'11", 350 pounds, his BMI was 42, and he was ordered for spirometry with bronchodilator. There was no improvement in spirometry after bronchodilator. However, there were low-flow, flat expiratory and inspiratory loops, which suggest a fixed large airway obstruction. Here's the patient's chest x-ray. As you can see, there is a large mass creating external compression of the trachea, pushing it into the right chest, and this patient was ultimately referred for immediate surgery. So thank goodness the patient's physician referred him for testing instead of assuming that his dyspnea was simply due to obesity. Key points: obesity alone can have a significant impact on pulmonary function, resulting in dyspnea. However, it is important to guard against the bias that all obese patients are short of breath solely because of their weight. Obesity-related asthma is real, and it is not uncommon. Serious, potentially life-threatening problems may go undiagnosed if it's just assumed that the obesity is the cause of the patient's symptoms.